We learned from the Breakwater study that there's a new way to treat BRAF V600E mutant colon cancer. In fact, they hit a 90% cure rate in that group, which, if this were a drug, would be headline news everywhere. Microsatellite unstable tumors treated with immunotherapy in this setting has a dramatic improvement on survival.
Why add atezolizumab to chemo for stage 3 MSI-H colon cancer? And does it really improve survival chances?
We learned at the recent ASCO meeting that microsatellite unstable tumors treated with immunotherapy in this setting has a dramatic improvement on survival. For example, in the ATOMIC trial, it was shown that 6 months of chemo plus atezolizumab followed by 6 months of atezo was associated with a 10% improvement in disease-free survival, which means that patients were 10% less likely to have a disease recurrence. Now, we've known this in rectal cancer in the early setting, pre-surgery, where we can even avoid surgery with the immune checkpoint agents. And we've known this in advanced colon cancer. But this was the first time we had seen a clinical trial really showing in stage 3 node-positive colon cancer patients that immune checkpoint inhibition adds a significant advantage to colon cancer patients.
What makes the encorafenib, cetuximab, and chemo combo better for advanced BRAF mutant colon cancer?
We learned from the Breakwater study that there's a new way to treat BRAF V600E mutant colon cancer. This typically is a terrible disease. They have a high propensity for metastases to the brain and to the peritoneum. So basically these patients do not do well with standard chemotherapy agents. Now, we've also learned over the years that you can target them by targeting that mutation with BRAF inhibitors such as encorafenib, and combination with cetuximab can be very advantageous in the second-line setting. What this trial, the Breakwater trial, showed was, number one, in combination with chemo, you can use the two biologic agents to improve disease-free survival, overall response rate, and even overall survival. All of those endpoints were met in this trial, which makes it a real landmark and sets the standard. For example, response rate was 65% in the EC, followed by or concurrent with FOLFOX arm. Overall survival was 30 months versus 15, and event-free survival was 12.8 months versus 7 months. So those are all very big differences with meaningful impact on patients' lives.
How does a structured exercise program after colon cancer chemo help patients stay healthier and cancer-free?
One of the most exciting trials presented at ASCO this year was the challenge study led by Christopher Booth and the Canadian group. In that trial, they demonstrated a definite advantage for structured exercise in colon cancer patients who had already received chemotherapy. The difference was about 6.5% in terms of disease-free survival, or a 7% difference in overall survival. In fact, they hit a 90% cure rate in that group, which, if this were a drug, would be headline news everywhere. The study was immediately published in New England Journal and is making waves because, number one, it's free, it's effective, and it's something we can recommend to all of our patients.
Can aspirin or celecoxib prevent colon cancer from returning in PIK3CA mutated patients? And how does ctDNA testing fit in?
Yeah, thanks. There's been a lot of progress in ctDNA, understanding ctDNA, and understanding how to use it in the surveillance setting. Another area we've seen development is who benefits from some of these adjunctive treatments like aspirin or celecoxib. In the original trial of C80702, there was no benefit at all to celecoxib, but in a subset analysis, those who had a PIK3CA mutation, they absolutely seemed to benefit from celecoxib, as did people with positive circulating tumor DNA. Now, those were both observational studies, so we don't know if we can use them to dictate practice, but the Alaska trial was presented in January at ASCO GI, and that was the first randomized trial to show that aspirin over placebo improved 3-year disease-free survival in a population of patients that were enriched for that PIK3CA mutation. In other words, 1,103 patients all had PIK3CA mutation. They were treated with aspirin, 160 milligrams, which is considered low-dose aspirin. The other group was treated with placebo, and there were these significant reductions in disease recurrence. So with that, I think we finally have a population that definitely benefits from aspirin. The data on celecoxib, I think we still need to wait and see, but there's progress.